Hello, everyone, and welcome. Thank you so much for joining us. We'll let folks get settled in and we will be starting momentarily. All right, again, welcome and thank you so much for joining us for our complex trauma and substance use in youth with our presenter, Elijah Jones. The views expressed in this training are the views of the speaker and do not reflect the official position of DHHS or SAMHSA. A few housekeeping items for you all. If you are having any technical issues, please individually message me, Alyssa Koala, in the chat, and I would be happy to assist you. If you have any questions for the speaker, please use the chat option for that. The speaker will respond to questions as time allows. If captions or the live transcript would be helpful, please locate that option using the Zoom toolbar. At the end of today's presentation, you will be redirected to a very short survey, and certificates of attendance will be sent out via email to all who attended today's session in full. If you would like to stay connected with the Great Lakes ATTC, follow us on Facebook, check out our LinkedIn, our YouTube channel, or our Spotify channel. I'm super excited to hand this over to our presenter, Elijah Jones. Thank you so much for being with us today.
Good morning, and thank you for having me. Good morning, everyone. Welcome to this webinar, Substance Use in Youth. Again, my name is Elijah Jones. I am a licensed independent social worker with supervisor designation and a licensed independent chemical dependency counselor in Ohio. I'm also a certified health education specialist and a certified diversity professional. My experience ranges from crisis, community crisis, psychiatric crisis, inpatient treatment, and substance use disorder treatment. I've done some work in integrated care in a collaborative care model and a family medicine residency program. I've also taught social work courses and chemical dependency counseling courses at some local higher education institutions here. Currently, I work for the Mental Health and Recovery Services Board of Lucas County. I am the Director of Programs and Services here. Lucas County is located in, I'm in Toledo, Ohio, so we're kind of the hub of Lucas County. And I am excited to be here to talk to you all about this interesting topic, substance use in youth. So I see a lot of you are getting started. I'd like to learn a little bit about you. So we'll use the chat a lot. I have it up on the side screen because I want to hear from you. Tell me, who you are, where you're from, what do you do, and what's your favorite emoji? Hopefully it's on Zoom, but I'd love to see that because I really like, as a millennial, I really like talking with emojis, and my favorite one the one I use a lot shifts from time to time. Currently, I'm using the one a lot that looks like it's melting. And I seem to use that for everything. So someone tells me, hi, and I'm, melting, or someone says, ask me a very serious question. Love the eye roll, the cool one. Yeah. Yeah, I don't know if it has that. I know this kind of mirrors the iPhone, but another one I love uh, kind of sarcastically is the salute one. So someone asks me a question, or my sister asks, tells me something, and I'm like, yes. Uh, um, so lots of the eye roll ones. I feel you there. Uh, all the yeah, yeah, so thank you. Thank you. It looks like I love to see a lot of people from Ohio, but we're looking for, I see some people from Michigan as well. Really close to Michigan. If you don't know, Toledo is, just a stone's throw away from Michigan. So really familiar with you all up there. Uh, so let's get started. So I'd like to just go over the objectives. I don't know if you've read these or not, but really this training is going to look at this intersection of adverse childhood experience, specific with more of a lens of complex trauma, and then substance use and use. We're going to look at, trying to understand this on a broader scale, the challenges related to youth and substance use, defining substance use through a trauma lens, describing the impact of trauma and substances on the nervous system. And we're going to learn to differentiate between treatment that re-traumatizes and treatments that's trauma-informed. And finally, we'll end with talking about some integrated trauma and substance use treatment. So again, you can use the chat for questions throughout. I love getting questions, but I want to acknowledge that a lot of this information comes from the Complex Trauma Training Consortium, specifically Module 6, which was developed by Dr. Deborah Broussard. I'm trained as a part of the Complex Trauma Training Consortium, so I'm one of the trainers. A lot of this information comes directly from that presentation, but also more on the youth. So what we're gonna focus on today. A lot of times, I've been in trainings. I've talked to people. We think of, especially with substance use treatment. I can tell you in Lucas County and probably generally in Ohio, we don't do well with youth and substance use treatment. We don't have many providers that provide really intensive treatment for this population. We have a little bit of outpatient availability, but there's not a lot of people doing a lot of work around this in our area. While some people are trying, there's still not a lot of availability. And so, um, typically when I hear the concepts we're going to be talking about today, it's really applied to adults in substance use treatment. And I think this is applicable because adolescents and youth become adults, and their adverse childhood experiences just don't disappear when they turn 18. But really, we're going to try to bring this back to actually working with youth. And I really define youth like loosely, between the ages of 12 and 18. You probably can go a little higher or a few years younger than that, but that's kind of what we're looking at today. So I want to begin today by really talking about the context of what we're looking at, because there's really kind of three big constructs we're looking at. We're looking at substance use, and we're looking at trauma. And these can have a very complex interaction, so that it's hard to kind of distinguish like what are we talking about today. And sometimes we're talking about all of them at the same time. Sometimes we're talking about them individually. So when we think about adolescent development, you are probably familiar, but just as a quick refresher, what does development look like during this time frame, about, 12 to 18, 19 years old? We're looking at physical changes. So puberty is starting. So youth are having growth spurts. There's hormonal changes. There's also changes in their cognitive abilities. They're shifting from more of that concrete thinking to more of that abstract critical thinking, long-term thinking. Now, I know working with youth, it doesn't seem like that because it's developing. It hasn't developed. Okay, so all this stuff is happening, and they're growing into this. There's emotional and psychological changes, so youth can experience like these intense emotions or fluctuations in mood. If you're a parent of a teenager, I don't have to explain that. You probably this morning you might have experienced some seemingly quick mood shifts. There's also some heightened sensitivity to social situations and being with peers. There's identity development. So during this time period, youth are developing their identity, who they are as a person outside of their family context. This is important as we consider trauma and complex trauma, but they're working on navigating complex social situations, peer relationships, and establishing independence from their primary caregivers. So a lot going on during the adolescent years. We know that that's not a surprise. For those of you who work with youth, it changes day by day, changes day by day. But when we're looking at drug use, we see that there is a significant amount of drug use, with zero being kind of the ideal amount of drug use. There is a significant amount of drug use we're seeing across the country. So, about between 12 to 17, about a little over 7% of youth reported using illicit drugs, including marijuana in the past month. 15% of high school students reported having ever used illicit or injection drugs like cocaine, inhalants, heroin, methamphetamine, hallucinogens, or ecstasy. 14% of students reported misusing prescription opiates, and 12.9 to almost 4.2% of 8th to 12th graders have reported using alcohol in the past 12 months. And when we're looking at drug use at kind of this national scale, we're just looking for these instances of drug use. It's hard to really really define the prevalence of what we would diagnose as a substance use disorder with youth. Just by going off these national statistics, but it's always great. And what we'll learn throughout this presentation, what we see in the research, early intervention, so including those screenings, and getting into people, getting youth into treatment earlier, sooner is going to be the best course of action. So really recommend screenings throughout this time period to identify problematic use, maybe before turns into a full-blown diagnosis, or to at least get those interventions in place. Um, we are, I've heard, so we also want to talk about why some teens experiment with uh, use. So we have a short video I want to show, and I'm sharing sound. I will double check to make sure I'm sharing. And I will turn on closed captioning.
It's really important to be able to get to the root of the issue, right? Why your child is misusing a substance. In no way, shape, or form would it be that a child would perhaps be thinking in their mind, I'm going to hurt, mom, I'm going to hurt dad, but that there are many underlying reasons. Perhaps they really don't know. They just know that they reach for it at certain moments, and they're not even realizing why. And a lot of times it's almost like someone asking you, hey, why do you like this particular dish at a restaurant, or why do you like that restaurant, right? You're going back because you like it. There's something about it that's engaging to you, whether it's the blends of the flavors, whether it's something that's capturing you, whether it's the lighting or the type of service that you're getting, whatever that is, it's drawing you back. And so now your child has to think about this, but in terms of their substance use, what's drawing them? That's what I want you to understand, that you and I, we're going to be able to have these conversations, because I'm all in. I want to know. I want to understand. And that you want them to keep sharing with you, and that you're available. You let them know that you're still there to understand. Because once you do, now we have a direction we can move in. Now we can, move toward discussing, what we're going to do about it. And how we're going to go about doing that. So in understanding the why is really important toward getting toward that place where we're getting that help.
So understanding the why of why a youth might be using drugs is really imperative, because this can, obviously this can change from time to time. Uh, and in what we'll be talking about today is really about, youth who use substances because of their complex trauma. But I'm interested to hear from your experience, if you work with youth, What are some reasons they report they use drugs or experiment with drugs or try drugs? And you can put those in the chat. Yeah, boredom, coping with anxiety and stress. We see a national really call to action about youth mental health, anxiety, depression's up, definitely peers, that peer pressure, that sibling. Yeah, we see a lot of peer pressure. Watch parents. Yeah, that's interesting. Thank you for that call out too, because what we'll learn is uh, on the when we talk about trauma, um, we know trauma can increase the likelihood of drug use. But then when we actually get into the specifics of those traumatic experience, we see like family drug use can be a trauma for youth. Someone said it's legal now. Yeah, so marijuana, illegal in several states, talks about how it's being marketed, definitely to look cool and be accepted among peers at peer pressures. Yeah, so we see some youth are curious. Curiosity is a natural part of the adolescent development, right? They're exploring their identity, who they are, peer pressure. During this time period, they're definitely influenced by their peers as they're developing out an identity outside of their primary caregiving system. Um, Natural better than vaping. Yeah, that's really that's an argument we hear around marijuana use. So, youth might be using just out of curiosity, due to peer pressure, out of boredom, to deal with symptoms of their own mental health, to deal with symptoms of trauma. Yeah, so understanding why youth are using is going to be important as we understand how we best help youth who are using and experience trauma. So, adverse childhood experiences and substance use disorders. I don't think I have to give a one-on-one on adverse childhood experiences to this group because it sounds like we have people who are have a lot of experience in this field. But really, from the Youth Risk Behavior Survey, we see the most common ACEs are emotional abuse, physical abuse, and household poor mental health. 3 in 4 students experienced at least one ACE, and nearly 1 in 4 students experience 4 or more ACEs. And uh, those with 4 or more, the highest were seen in females, followed by Alaskan natives or Native Americans, those multiracial, and those LGBTQ students. Um, so I want to focus on this most common ACEs because that is going to be key to understanding this definition of complex trauma, which we will go over shortly here. And that's what I want to frame this presentation in this complex trauma and what that is. So while all of the information is applicable to adverse childhood experiences, there's some nuance when we're understanding what complex trauma looks like in these youth. So adverse childhood experience and substance use. The higher the ACE score, the higher the chances of addiction to alcohol and other drugs in adulthood. So 4 or more ACEs, there's a 500% increase in risk of adult alcoholism. Men with 6 or more ACEs, there's a 4,600% increase in risk of IV drug use. I'm not a math person. That sounds like a lot though. 78% of IV drug use in women can be attributed to adverse childhood experiences. So we see this strong link between experiencing, having these adverse childhood experiences, and the likelihood of becoming addicted to drugs. And addicted in this context is obviously, long-term use or use over time. So complex trauma, what is it? A lot of people talk about complex trauma as experiencing several traumas. And some people have kind of a very loose definition. For this presentation and the trainings within the Complex Trauma Training Consortium, we're talking about complex trauma being a dual problem. It's an ongoing or recurrent exposure to interpersonal trauma, typically originating in the context of a child's caregiving system, and the consequent developmental deficits and emergence of psychiatric and behavioral disorders. So why did I say that's important? The four most common ACEs we see among high school students are emotional abuse, physical abuse, household poor mental health issues. And what do we see? This complex trauma is a trauma that originates or occurs in the context of a child's caregiving system. And because of that, there are developmental and psychiatric issues and behavioral difficulties we see. So the most prevalent risk factor is exposure to a combination of impaired caregiving due to parental substance use, mental illness, or intimate partner violence. We saw, the third most common ACE is the parental mental health issues. We saw that, youth use because someone said in the chat, youth use because they see their parents use. But there's also neglect, emotional abuse, and physical abuse. And this constellation of adverse experiences, often referred to as complex trauma exposure, if unmitigated through early intervention, increases risk for subsequent trauma exposure, including caregiver separation or loss, school and community violence, bullying, or assault. So public health and applied clinical research link these forms of trauma exposure to substantive developmental deficits and worsening diagnostic, functional, and social impairments. Neuroscientific research indicates that these maladaptive outcomes arise in full or in part as a result of survival-based adaptations to early trauma. So survival-based adaptations to early trauma and the array of resulting adverse outcomes is often referred to as complex trauma. Complex trauma exposure intersects with other pervasive forms of life adversity, including systemic racism, poverty, intergenerational trauma, and ancestral or historical trauma. So really, in the research, we see that having these ACEs, particularly 4 or more, relates to lower resilience. So the ability to bounce back, the high to get through life challenges. This then leads to higher rate of depression, which then leads to increased drug addiction. So we see this trajectory that ACEs lead to lower resilience, leads to higher depression, and then we see this increased drug addiction. So what is addiction then? There's lots of there's lots of models of addiction. If you've been in the field for a while, you've probably heard of all of these or some of these. Um, I really think of a kind of an integrated model of what we understand addiction to be, that is pretty much encompassing of all these definitions. So the NIDA defines as a disease. Addiction is defined as a chronic relapsing brain disease that is characterized by compulsive drug seeking and use despite harmful consequences. It is considered a brain disease because drugs change the brain. They change the structure and how it works. But Dr. Gene Hyman in 2013 wrote Addiction, a Disorder of Choice. And really, he talks about how this it's a choice to use drugs, but it's also a choice to stop using drugs. And there, in his research, there are some merits to this, but it's kind of a call out. Just we can make better choices. And obviously, there are lots of critics of the choice model. It's different than this historical moral failing model that we were familiar with. Um, and there is a lot of the disease model of addiction is pretty prevalent. It's really based on, how we use the medical model here in the United States. Now, Dr. Mark Lewis wrote The Biology of Desire, Why Addiction is Not a Disease in 2015. And in it, he talks about how uh, it's a normal brain response. So in this, he talks about habits, and drug use becomes a habit, and habits modify the brain structure and creates new brain patterns. So this is really a nasty, relentless habit that includes thinking, compulsions, and desire. But within this, we understand that, as habits change brain structure, uh, drug use changes brain structure. It's actually not a disease because it's a normal response. If you do X, then you get this. So if you are developing a habit around drug use, then yes, your brain responds to that, and you are at risk of developing addiction, and that's a normal brain response. Um, so there's merits to this. Definitely, again, controversy over falling back to that moral failing viewpoint that we've had for addiction for a long time. However, this kind of shifts the focus as like it's not a disease in that it is a normal response, and the brain is functioning actually how it should, while it is a maladaptive and bad habit for you. It's still a habit, and the brain is responding accordingly. There's also response. It's been as a response to the social environment. So, social dislocation theory, as it says that addiction is a response to societal factors that leave people feeling disconnected from each other and their community. And so, addiction is really a social response and not just an individual response. So, you might have seen talk about like the opposite of addiction is connection. Really, that is saying, people need to be connected to each other. They need a community. They need to feel supported. We understand this, in trauma because, you need supportive, healthy people in your life you know, um, to build resilience. So, in this context, when we're thinking about addiction, this kind of makes sense too. And then finally, an attachment disorder. Substance use is a consequence and solution for impaired attachment relationships. This probably makes a lot of sense as well as we think of complex trauma occurring in the context of a child's caregiving system, where early attachment is formed, where behavior is modeled, where we learn to cope and manage and navigate relationships and build trusting relationships with complex trauma that is really hindered because that trauma is occurring in the context of the caregiving relationship. So attachment really, this it can be viewed as attachment disorder as a way to, as a consequence and a solution for attachment related issues. There's also the self-medication theory, and you all kind of talked about this a little bit in your comments in the chat. But people who become addicted suffer because they have difficulty regulating emotions, sense of self-worth, relationships, and behaviors. So they're self-medicating in order to deal with or cope with or regulate these emotions, sense of self-worth, relationships, and behaviors. And really, this theory kind of encompasses adolescence, right? Adolescents are dealing with emotions, their sense of self-worth or identity, navigating relationships, uh, navigating their own behaviors, learning to, better self-regulate, experiencing more of the long-term thinking, understanding more of those uh, actions have consequences. So self-regulation or self-medication theory actually makes a lot of sense in this context as well as we think about complex trauma, substance use, and adolescent development. So within this, drugs are used to medicate specific symptoms. So opiates are powerful anti-aggression and anti-rage agents. So taking opiates may be an attempt to um, regulate feelings of anger. Depressants have a relaxing effect on tense, rigid defenses. Stimulants energize and activate, or paradoxically, they can calm depending on the individual. So in the self-medication theory, the drug of choice may reflect the symptom the individual's experience, and polysubstance users may be trying to medicate both hyper and hypo active symptomology. So they might be trying to regulate these feelings, these intense feelings, and uh, these feelings of depression and feeling needed um, to relax and calm. And to answer your question, this is a 90-minute presentation. So what is the impact of trauma? So trauma creates a vulnerability to addiction. We've established that. So we have this model of ACEs and this decreased resilience, increased depression can lead to addiction. Complex trauma occurs in the context of a caregiving system where self-regulation is learned and practiced and modeled by parents and caregivers. But trauma interferes with that. It decreases capacity for self-regulation, and there's a compromised ability to form healthy attachments. So this is significant for youth because they're still developing those self-regulation skills. While, many adults are developing, practicing self-regulation throughout their life, this is still relatively new for youth. They're still working on this. So we're still identifying these when their body feels activated and what to do about it. So trauma decreases the capacity for self-regulation, and complex trauma specifically because it occurs in that intimate connection of that primary caregiving system. And youth are working to form healthy attachments outside of their immediate family. So, from up until this time, that identity has been primarily with their family, their immediate family, and youth are developing attachments and relationships outside of that. So the lack of ability to self-regulate, lack of ability to form healthy attachments within the primary caregiving system and then mirrored outside of the primary caregiving system creates a recipe for substance use. So what is addiction? I want to show this video of Dr. Gabriel Maté, a world-renowned speaker on the issue. So I will do that now by sharing my screen and sound. We'll make sure we have closed captions.
All the substances of abuse, whether they're opiates or cocaine or anything, are painkillers. Some of them specifically are painkillers. But physical pain and emotional pain, the suffering is experienced in the same part of the brain. So when people suffer emotional rejection, the same part of the brain will light up as if you stuck them with a knife. The Eckhart Tolle says very nicely that addictions begin with pain and end with pain. So that all the addictions are attempts to soothe the pain. So when I work with addictions, the first question is always not why the addiction, but why the pain. And what you find is emotional loss or trauma. In the case of the severe addicts, as in the downtown East Side here, they were every single one of them traumatized. There's no women walking the streets here who have not been sexually abused, not even by accident. But you know, whether it's a sex addiction or internet or relationship or shopping or work addiction, these are all attempts to get away from distress. Keith Richards, the Rolling Stone guitarist, said, who used to have a severe heroin habit, as you know, he said that all the contortions we go through just not to be ourselves for a few hours. Well, why would somebody not want to be themselves? Because they're in too much distress and too much pain. It's not about genetics or any of that choices or any of that nonsense. It's always about pain. Well, the Tibetan Book of Living and Dying, it's got a wonderful line in it. Whatever you do, don't try and escape from your pain, but be with it. Because the attempt to escape from pain is what creates more pain. And that's the reality with addiction. But the question is, how can people be with their pain? Well, only if they sense some compassion from somebody. So as another teacher says, only when compassion is present will people allow themselves to see the truth. So addicted people need a compassionate present which will permit them to experience their pain without having to run away from it. And all the attempts to run away, it's like another teacher says, the surest way to go to hell is to try to run away from hell. So you got to be with that pain. You just have to be with it, but you have to have some support. And we live in a society that, one way or the other, is always about instant relief, quick satisfaction, distraction. In other words, we live in a culture that is based on, both economically and psychologically, on not supporting people to be with themselves. So it's always the quick getaway. So it's very difficult to deal with addictions in a society. But yeah, it is a matter of, at some point, finding a way of being with your pain so that you can actually get to know what it's really all about.
So someone asked if the link can, and we can provide that after this. I have no problem. It's available on YouTube free. So I see, some reactions to the video. I am curious, though, as you think about these different definitions of addiction, complex trauma as trauma occurring within the context of a caregiving system. We know the most common types of trauma in the national study, um, uh, physical abuse, emotional abuse, impaired giving is giving due to parental mental health. Um, and we just watched this video. What are you thinking right now about complex trauma in youth? isolated. Yeah, how isolated they are from support's great, and that is actually a reason, one of the theories around addiction, social isolation. Our society causes more trauma. Yeah, that's a great call out. While complex trauma is in the context of that caregiving and relationship, it doesn't neglect, it doesn't negate all the other traumas a youth might experience. Uh, social and emotional behaviors in their life skill classes. Let's see, youth need more guidance on how to process big emotions, navigate healthy choices. Yeah, and you can kind of see in that definition or that model of addiction with making that choice theory of addiction. But youth are experiencing big emotions because that's what youth do during this time. They are having big emotions. Their bodies are changing. Their chemistry is changing. Their brains changing. Their relationships are changing. They're in this constant state of change, and then layer on this complex trauma, this impaired ability to self-regulate because we learn to self-regulate in the context of our caregiving system where the trauma is happening, and layer on substance use, which drugs can be used to mitigate symptoms of or the effects of trauma, the symptoms of their emotional, behavioral, mental health. And then, we might see that youth are thinking they are regulating appropriately. You know, I've talked to people who, smoke weed in an attempt to self-regulate, but they're really just zoned out. Um, Someone said they're going through so many experiences and feelings and have little guidance on how to navigate. Yeah, that guidance comes from caregivers, right? Trusted individuals, and those are lacking for so many youth. Very chicken or the egg, whether substance use or trauma occurs first, they seem to stay connected. Yes, thank you. And that's why I said adolescence, trauma, substance use, it's kind of this web, and it's hard to, not even like a spider web, more like a, a net of knots, and differentiate what exactly are we dealing with here, or is it all of them at the same time? So great. Thank you for all these comments. I can't get through all of them. I wish I could read all for the recording, but someone said attempting to escape from anything has never given us the skills to resolve it. We just place a band-aid over it and wait for it to come off again. Yeah, I think the video when he said, addiction starts with pain and ends with pain. It's, for some it's an escape, um, and escaping doesn't solve the issue. They don't always have to experience, they don't always have experience with trauma. So it could be bigger than it would be for someone older and with more life experience. That can older people think they're being dramatic. Yes, yes. That's why I think, it's so important, especially, in my experience working with youth and their families, it is critical to educate families on what development looks like, you know, and what we can expect and what typical development looks like, but not in, we have these stages of development. You're familiar with Eric Erickson's stages of development, but not that these are these exact cut off, like from this age to this age. They're about and kind of what we can expect. But some kids might develop faster, some kids might develop a little slower, and it's all fine. We're talking about these generalities of what we can expect over time, and parents need to hear that. Um, and that is part of our role when we're working with families to provide that education on, what development looks like and and also the impacts of trauma. So we watched Gabriel Mate's What is Addiction? Um, Continuing on, substance use through a trauma lens. We've already started applying this trauma lens. I would say, but uh, Vessel van der Kurt says people with PTSD have their floodgates wide open. Lacking a filter, they are on constant sensory overload. In order to cope, they try to shut themselves down and develop tunnel vision and hyperfocus. If they can't shut down naturally, they may enlist drugs or alcohol to block out the world. I don't know if you've ever talked to a youth or an adult who's described their drug use like this, but through a trauma lens, we see that substance use is a maladaptive coping strategy for traumatic stress. So, um, earlier we talked about complex trauma and survival strategies. So youth are, through a trauma lens, youth might be using drugs and alcohol or these substances as a way to cope with the traumatic stress they have experienced or are currently experiencing. Because while youth are trying to develop an identity outside of their primary caregiving system, they're impacted still by their primary caregiving system. They're still in the midst of their primary caregiving system. And that's why I always remind the social workers I get to supervise and their training supervision, like working with youth is working with families, and it's very difficult because youth don't always have the same autonomy to change their environment. While they might, especially in treatment, they might be they might be being hurt by they might be continuing to be hurt by the very thing we're trying to address in treatment. So, when we see a youth maybe in our office for, maybe outpatient therapy or something, or some education or something, we send them back home to an environment that might be continuing to hurt them. So it makes sense then, through a trauma lens, if youth are enlisting drugs or alcohol to maybe block out the world to address the stress related to what they're experiencing, that becomes a coping strategy or survival strategy, a way to cope with what's going on. So, we're shifting our lens or changing our lens in our approach to treatment. So obviously a trauma-informed approach shifts from something is wrong with you to something bad happened to you. So, in this, we want to reframe addictive behaviors as protective behaviors and survival strategies. Youth who've experienced complex trauma, youth who've experienced multiple ACEs are trying their best with the tools and resources they have, which may be very limited because remember, they haven't fully developed those self-regulate. So youth in general haven't fully developed those self-regulation skills, and the place where they learn those self-regulation skills has been impacted by trauma. So, they're not working, they don't have a lot of tools to work with yet. And so we can reframe addictive behaviors as protective factor behaviors and survival strategies. They're working with the tools they have. So while the initial use of substances by a traumatized individual makes sense based on the trauma history they're experiencing. So trauma reactions, you are familiar with these, I am confident here. So we see the common ones: fight, flight, freeze. Fight looks like it's a type of mobilizing response. They're ready to counterattack. Their nervous system becomes dysregulated or is chronically dysregulated because of the environment they're in. They might be hyper vigilant to threats to their environment, so they're always on edge, ready to fight. So this fight is a mobilizing response to a danger or threat to their survival. Flight, another type of mobilizing response. It occurs when there's that threat to safety and the person is getting out of there, they're running or fleeing. Freeze, this is a type of response that is different than fight or flight, but the person freezes. They uh, uh, are trying to cope with what's going on. The freeze response is immediate stilling of movement with vigilance to the threat and in preparation for a fight or a flight response. So this freeze response in this context here um, is not is not solely in place of a different response. It can be a preparation for a fight or flight response. Submit this type of response, and this is these other ones are you kind of if you are familiar with these presentations, you're hearing these other types of reactions to trauma more and more. Submit, fawn, tend, and befriend. Submit as a trauma response that is often considered the defense response of last resort. It's how the nervous system often handles chronic and escapable trauma. In a moment of trauma, the defense response can lessen the person's experience of pain. It's compliance, it's obedience to whatever's going on, and it attempts to lessen the pain in the moment. Fawn, this response is instinctual response associated with the need to avoid conflict and trauma via appeasing behaviors. So, there's still that threat to the person's safety. Their nervous system is still activated, but instead of fighting or fleeing, fawn is this attempt to appease in order to maybe lessen the lesson what is going to happen. And tend and befriend is this is a typical or predominantly a female stress response model that adds a dimension to the fight and flight or freeze concept and suggests that women and other women particularly respond to stress by engaging in activities of care and connection. So trying to tend and befriend in hopes that this trauma or this threat to safety will change, will end, will no longer be that same threat. So protective behaviors and or survival strategies. Remember, this is what we're shifting to when we're thinking about youth who have experienced complex trauma and are using substances. We're looking at these more as protective behaviors and or survival strategies. So blame. These behaviors are really common in treatment and are typically labeled as addictive behaviors or behaviors of addicts, quote unquote. We try to avoid using that term, but really these are some common behaviors we see when people are in addiction treatment, especially early in on addiction treatment. But we can reframe these behaviors as actual protective behaviors and survival strategies. So blame, a person might use blame as a strategy when they might have experienced severe punishment for misbehaving. And so that blame becomes a strategy to shift the punishment to someone else. So, when someone is confronted with someone, in treatment, when you confront a client with something, they might shift to blame because they have experienced severe punishment after something or punishment related to something they didn't do. So their instinctual response or their survival strategy is to blame someone else in order to avoid the punishment. Aggression. This can be a fight response as a way to keep to keep others at bay. So if someone is aggressive, then that might be a way their person is trying to keep themselves safe from others. Remember, Complex trauma, and I repeat this over and over, complex trauma occurs in the context of a caregiving system. It is with family, it is with close caregivers, the people you are supposed to trust the most, the people who are supposed to keep you safe, have actually caused harm. And then youth are expected to go out in the world and just automatically, or not automatically, but they're expected to trust other people, especially people in authority, just because they're in authority. So aggression becomes a survival strategy to keep people at bay for their own safety. Non-compliance. Uh, so when you tell someone to do something, that can be triggering. You know, non-compliance in a treatment program can be driven by fear that they cannot survive emotional dysregulation without substances. So stop using substances, or to stay in treatment, you can't use substance anymore. Non-compliance may be a way, maybe a behavior related to their fear of no longer using, no or not having the tools to self-regulate. High maintenance, that's a type of attachment response. Um, it can be it can help the person feel a sense of control when so much of their life has been they've lacked control. So this type of behavior or survival strategy uh, is really an attempt to try to find control in a situation where they don't have a lot of control. Superficial compliance, you might, if you've worked with kids for a while, you might see this. They've learned to do just enough to stay under the radar. They've, especially if, in that context of caregiving system where they experience punishment or abusive caregivers. You didn't want to make waves radar. So the superficial compliance is can be an attempt just to stay out of the person with authority's radar. Manipulation. I've heard this a lot in treatment, but manipulation is a way people get their needs met. Um, so youth who've experienced this complex trauma may not be intentionally manipulating for nefarious reasons, but they're doing their best to get their needs met, and this is how it's worked for them, and this is how they're finding it's worked for them. Focusing on others, this takes attention off yourself and reduces the chance of being called out on your own behaviors. So, shedding light on other people, what they're doing. And we see this in youth anyway. When you talk to youth about their behavior, especially if it was in a group of people, you might hear something, but everyone was doing it. We were all there. We were doing it. So it's an attempt to take the focus off themselves. Dishonesty. Sometimes youth who've told the truth would get punished. So dishonesty can be a way to protect self from a perceived threat of punishment. And relapse. Not using substances requires clients to face the emotional distress of trauma. And that relapse can bring relief. That relapse, or starting to use those drugs again, can go back to helping with those symptoms that they were trying to use the drugs medicate with, or to regulate certain symptoms with. So these common behaviors, these common things we see in addiction treatment can be very frustrating in the moment. But when we start viewing them as protective behaviors and or survival strategies, we start to understand more of why an individual is engaging with these. And when we understand the why, we're able to develop better strategies and interventions to address what people actually need. And, you know, when we think about connection, like our systems are typically trained to disconnect from people. Oh, you're in treatment and you're continuing to use. We're going to have to discharge you for noncompliance. We're going to have to cut off this relationship we've been working to build because you're still experiencing symptoms of what we're trying to treat. uh, when we view it in this context of trauma, it makes no sense. Especially if we think about trauma or addiction as a response to social isolation and loneliness and feeling disconnected. The we we're further traumatizing youth and adults because we're disconnecting from where they're getting their support from. So obviously there's impacts on the nervous system. Trauma, starts reshaping the brain. Drugs have impacts on the brain, but trauma impacts um, that uh, has significant impacts on that nervous system, that stress response system, where our body reacts to threats in the environment, where we have these responses of fight, flee, freeze, fawn, tend, befriend. Um, so there's the hyperactive amygdala, that's that the brain's fear center becomes overactive. There's hypoactive prefrontal cortex that can function in emotional regulation, um, become underactivated. So there's an overactivation of that fear response system and under underactivation of the executive functioning, that prefrontal cortex where emotional regulation happens, where long-term thinking and planning happens. Um, and in youth, these are still developing. So complex trauma becomes more pervasive because it's impacting these systems that are still developing. And uh, this high levels of cortisol may cause structural changes leading to memory deficits and difficulty distinguishing between past and present safety. So, um, significant and complex trauma and trauma in general have significant impacts on the nervous system, especially complex trauma, uh, in that, there's this there's challenges to self-regulation, regular dysregulation, and inability to kind of uh, get that prefrontal cortex back online to regulate. So there's also this bridge between trauma and addiction. So chronic substance use, substance use, long term over time, hijacks the brain, making it hyper responsive to drug cues while reducing its ability to feel pleasure from natural rewards. And then trauma also dysregulates the system because chronic stress can lead to a lower functioning reward state where an individual feels emotionally numb or unable to experience joy. So trauma, you know, leads to dysregulation. That chronic stress um, impacts that reward system. So people feel numb and unable to experience joy on top of the addiction, which hijacks the brain, making it responsive to feeling pleasure from drug use versus natural rewards. So it's kind of this vicious cycle that people can experience. Um, that is kind of this dual process happening at the same time. Trauma leads to dysregulation and a lower functioning reward state, while chronic substance use um, increases that hyper responsiveness to drug cues and reducing that ability to feel pleasure from natural rewards. So when we think about treatment or addiction treatment, one must not look hard to see that we are losing the battle against addiction, you know, and we have lots of studies over many, many years that have mixed results with treatment, especially with adults. We see some studies might show high rates of success, while studies show low rates of success or low rates of long-term success. But I want to talk about the literature around treatment for youth, or outcomes, the treatment outcomes for youth. So, in some of the meta-analysis, we see that there is a broad effectiveness of active treatment with nearly all types of treatment, showing significant improvement and reductions in substance use from start to end of program. So, treatment is always better than no treatment. So it doesn't matter what the treatment is. If it's something or nothing, something is always better than no treatment. Most active treatments were beneficial, but family therapy, cognitive behavioral therapy, emotional enhancement therapy, behavioral therapy, and assertive continuing care were most beneficial. Family therapy and cognitive behavioral therapy show particular promise in achieving the largest reduction in substance use. And these studies really looked at reduction in substance use. Which doesn't necessarily equate to an ability to self-regulate or improved ability to self-regulate, but in the studies we're looking at the largest achievements, reductions in substance use. Practice as usual or standard community services were consistently the least effective. So not providing a service or just referring someone to like a community support, maybe getting someone involved with, let's say, a sports or something. These were consistently the least effective methods. So treatment is always better than no treatment. Step care has been shown to be less effective than integrated care, so addressing the substance use, mental health, and medication needs upon starting treatment. So in this context, step care is like you come in, you try the lowest thing first, then you kind of go up. When integrated care or step care, you might address like substance use disorder, and then you finish that treatment, then you do mental health treatment separately. But integrated care looks at addressing substance use disorder and mental health and medication needs when you start treatment. So after the assessment process, the treatment plan looks at addressing all these at the same time, which that makes sense, but people are still not doing it that way. Compulsory care or forced treatment can actually be harmful or lead to higher rates of recidivism, and continuous engagement, even during periods of relapse, is critical to positive long-term outcomes. So continuous treatment, even in periods of relapse. Why? We've talked about this previously, but people need connection. Sometimes a trauma reaction can be to relapse. It can be go back to those old habits because that is what's safe. That is what they know. That is what their body has used to feel regulated, to feel safe. So going back to those things can be common for people, but that is the time when actually treatment needs to be more proactive and engage more, not less. Because we want to continue that connection. So addiction treatment has a interesting history. It evolved in relative isolation from mainstream healthcare, although now we view it within a disease model of a chronic relapsing brain disease. It hasn't always been viewed like this. Now we're definitely more in line with the medical model, especially, we have the American Society of Addiction Medicine has specific, levels of care, and those are defined. There's ways to kind of articulate which level of care, assess what level of care is best for an individual. But in its history, it really was an addiction treatment, um, didn't evolve with mainstream healthcare. It evolved separate as an alternative system. And we see that, that's really the development of like Alcoholics Anonymous. When, people did not go to a healthcare system for that. They went to Alcoholics Anonymous, and people who have had lived experience help them through that. Today, there's impassioned debate regarding the use of evidence-based practices. But this can be traced to the origins that, it developed outside of the healthcare system. It developed outside of, um, academic institutions and the um, evidence-based treatment. It really was about folk wisdom and lived experience. The lived experiences is of people who had gone through addiction and found their path to recovery. So now, while we know there are evidence-based practices, there's still debate on, how addiction treatment should be rolled out, particularly with adults, though. But when treatment's not trauma-informed, uh, it can lead to, poor outcomes for people. And it, often challenge when we're seeing people leaving treatment unsuccessfully or being discharged, we have to ask, was our treatment actually trauma informed, and not just what did we actually view the individual through the lens of trauma, or did we fall back on what we're used to doing, which is a primary focus on consequences and compliance and changing behaviors with little attention to what drives these behaviors? Remember, I said the why. We need to understand the why, and that is unique to each individual. Why they're using the substances. How, how what is their history, what type of trauma they've experienced, because that helps drive treatment. But when we lump everyone together and we focus on completing programs and compliance to the rules, and changing behavior, we're actually not being trauma informed. So well-intentioned treatment strategies can re-traumatize a trauma survivor and trigger instinctive trauma responses, leading to non-compliant, not to uncompleted treatment. So we talked about those behaviors. Someone whose caregiving system might have been authoritative and abusive and demanding, and then we put them in treatment that's authoritative and demanding, and we expect them not to have these instinctual reactions to this threat that they've grown up with. Um, and then they don't complete treatment. That's why it's so important to understand what is driving these behaviors, and that is how we become trauma informed. So treatment can re-traumatize a trauma survival. It reinforces this concept of powerlessness. I am, a victim in, the rules and the system in place. There's this absolute authority of the counselor, where, counselors, can tell a probation officer this person is non-compliant, and then there's repercussions because of that. We use, there's confrontation tactics in treatment. And while there is some lived wisdom in that, it can be re-traumatizing, especially for victims or those youth who've experienced complex trauma. Shaming practices, I don't have to go into detail about that. There's this focus on character defects. We that is kind of that legacy of this moral failing, that people have these flaws in their character that is that is why they're using. Addicts lie. That's so common in treatment. But we can reframe this behavior as a way of coping, as a way of surviving. Why would you tell the truth if there's a threat to your safety? If you're perceiving a threat to your safety and you feel a lie can, keep you safe, why would you tell the truth? Um, we discharge for noncompliance. We've talked about that. We punish aggression. When we talked about aggression can be a way to safeguard from other people, keep people at bay to protect yourself. We don't um, we don't give choices often. We say, here is your plan. That so often isn't made with the person, it's given to the person. And there's no choice or very little choice. And we know that one of those pillars of trauma-informed care is providing those choices. Some people still consider medication assisted treatment as not sober. I've been watching this couple do this series on TikTok of like, I think it's like fake sobriety, and um, they're actually, in recovery, but the way they've done recovery is not, people consider that as not real recovery. So they talk about their fake sobriety, but people still consider these medications as not real recovery, or that they're not sober because they're replacing maybe an illicit drug with a prescribed controlled medication. Oftentimes, we require 12-step involvement, and 12-step programs are great. 12-step programs have helped so many people. Um, I've talked to so many people in treatment who talk about, every time I'm in a meeting, I know I'm not using. And, that is their way, their path to recovery. But to require and force it is not a trauma-informed um, response. And told not to talk about your trauma. We've seen this, especially with youth. Um, we tell them not to talk about the trauma, not to talk about what's going on, not to talk about these really their life. And when when I worked in inpatient with youth, this was common. We talked, you know um, when I went to school, trauma informed care wasn't even talked about. So when I entered the field, I didn't get a lot of this information until I was well years in the field. So, when I was inpatient, I was working with a lot of nurses, and they told the youth, like, you don't want to make friends here, because making friends here is like making friends in, like, you're making friends in jail. They're just not good. um, they're just they're just not good people to be friends with. And now, through a trauma-informed lens, people should be talking about their trauma and providing peer support. Um, so this paradigm shifting from punishment to safety. Obviously, we need that safety in treatment. Um, that's paramount to it. So there's psychological safety, but also environmental safety. And when there's punishment, people can't let their guard down. If that is the philosophy of the treatment, to punish people who are experiencing symptoms of trauma and addiction, then it's not safe, and people can't open up and be in a position to learn, especially because early on in treatment, a lot of it is learning, and you need to be able to self-regulate in order to learn. So moving from distrust to trust, we need to trust the stories people tell us, the narratives they're giving them. And if we can show trust, we can start to build trust, and we can work through when um, behaviors are leading people to not tell the exact truth. Confrontation to collaboration. Um, we don't do treatment to someone, we do it with them. So from, from the start, from assessment to planning to intervention, this all needs to be in collaboration with the person we're working with. Authoritative treatment to choice and empowerment, empowering people to make choices in their own recovery. And when something doesn't make sense to them, that is all, we should not be requiring. That's also related to cultural competence. We can't just assume this exact treatment is one size fits all. We need to be responsive to what people are bringing and compliance to transformation. We don't want people to comply or give that superficial compliance to get through treatment. We want them to transform and heal and be in recovery. And this only happens when we address that root cause, that why of what's going on. So rethinking addiction treatment requires a new lens. Addictive behaviors are often an adaptation to traumatic experiences. We need to think beyond this mere disease model of addiction, incorporate these other models, these that around connection and the a natural brain response and attachment. And when we do this, we can start having greater tolerance for harm reduction. So when people are relapsing or using again, our automatic response is not, okay, we need to discharge you from treatment, but to further engage and work with the individuals. So there's a number of evidence-based treatments for substance use disorder. You will have access to this PowerPoint. You are familiar with these. You probably have been trained in a lot of these. We talked about cognitive behavioral therapy and family therapy as being key when we're the best for substance use reduction, what we see in the literature. There's also some specific trauma treatment interventions that I would encourage you to explore and get trained in. These can include trauma-focused cognitive behavioral therapy, cognitive processing therapy, attachment regulation and competency, EMDR, DBT, prolonged exposure, internal family systems, sensory motor psychotherapy, and somatic experiencing. These all require additional training, but all can be very powerful in treating trauma for youth who've experienced complex trauma. So there's also some specific integrated substance use and trauma treatments. These include seeking safety, the addictions and trauma recovery integration model, helping women recover, helping men recover, trauma recovery and empowerment models, I-Care, which is integrated care for adolescents struggling with traumatic stress and substance use, integrative treatment of complex trauma for adolescents, and risk reduction through family therapy. So again, these are more evidence-based treatments that you might consider that require some additional training and investment. So ultimately, we need an integrated approach to treatment. We need to be treating both mental health and substance use upon entry, but we also need to be treating that mind-body connection. So using breath and movement and touch, grounding and strategies that get us out of the emotional brain to help youth self-regulate, safe and relational connection, modeling what that looks like, and then the cognitive using mindfulness education, talked about educating families on youth development, by educating families on substance use and the impacts of trauma, challenging cognitive distortions when appropriate, and strengthening executive functioning. This is key for youth. Remember, they're still developing that prefrontal cortex, but further strengthening that can really help re-engage that. So youth, when they're dysregulated, can start regulating more quickly. So recommendations based on what the literature says. Early intervention and immediate access. We need to address needs as soon as they're identified. So implementing screenings and appropriate referrals, understanding that not everybody's going to be doing treatment here, but if you're in a position to offer some screenings and then make appropriate referrals, that can go a long way to identifying needs sooner. And the sooner we get people into treatment, any type of treatment being with the alternative as no treatment is better. Comprehensive tailored treatment. So treatment superior to no treatment. Treatment should be developmentally appropriate and trauma informed. So I think, one thing that's important, um, the providers need to be trained on youth development. You can't take someone who's done adult therapy for 20 years and just put them with youth and think it's going to be the same. Providing education on trauma, youth development, and the impacts of both. People should be voluntarily engaged, and we need to continue that engagement during relapse. And we need to prioritize evidence-based modalities, especially family therapy. Um, and treatment for youth requires skilled and competent staff. So here's our objectives. Did we get there? We described the relationship between ACEs and trauma and substance use. We articulated a broader understanding of substance-related challenges in youth. We worked to define substance use through a trauma lens, describe the impact of trauma and substances on the nervous system. We worked on differentiating between treatment that re-traumatizes versus trauma-informed treatment, and we described some integrated trauma and substance use treatment models. So with that, thank you so much for being a part of this presentation. We have a few minutes left. I can go through any questions. There is the evaluation certificates will be emailed to you after. You will have access to the PowerPoint. We'll get you the link to the presentation. If I'm assuming we can get that to them.
Yep. So I have the PowerPoint and the fact sheet on our website, and I put the link in the chat. Once we
Great.
close the Zoom room today, I will be processing that recording and getting that up on our Great Lakes ATTC website by the end of the day today.
Yeah, thank you. And also there is kind of a resource for you that's not the PowerPoint that you can use and maybe give out, and just some reminders and some further things to do. So I don't see any specific questions. I did not anticipate this many people being here. So if I did miss some, I apologize. Feel free, if you have questions after, I'll put my email in the chat and you can email me after. Am I presenting again in the near future? Maybe, I don't know. I was just invited to do this, and I'm grateful that the ATCC asked me to be here today. Can we put them in the chat again? Yes. We can put those in the chat again. And the PowerPoint and recording will be available on the website.
Well, if we don't have any additional questions for Elijah, I just want to say thank you so much for presenting for us today. It was such a wonderful presentation. I'll just remind everyone a little bit again, please make sure you fill out that post-event survey. Certificates of attendance will be sent out via email to everyone who attended today's session in full. And then Elijah did put his email in the chat. So if you ever have any questions that come up later, feel free to email the Great Lakes ATTC and we can pass it on, or email Elijah. And like he said, he would be happy to answer any questions you may have. And then since this session is part of a series, make sure you check out all the sessions in the series. We have all the recordings on our website, and session 5 takes place on April 28th. So make sure you check that out and register for our next session. And I won't keep you any longer. So thank you all for joining us today, and I hope you all have a great rest of your day. Thank you so much again, Elijah.
Thank you.